Make a presenter, okay?
I have done it.
Okay, sir.
Sir, please share screens. Press the start webinar later on once the presenter is there already. So
I'm very new to this webinar, sir. I'll get used to it.
Okay.
So please do the slideshow, sir. Dr. Prasad. I will introduce Dr. Prasad. Dr. Prasad is a former HOD pathology professor at present at Devraj URS Medical College, Kolar, Karnataka. He has trained in NABL QMS quality assurance of internal audit training, and he is a PG diploma in genomic technology as acquired, and he has a lot of research publications. And he has extensive passion for teaching, and he has around 20 to 25 years of teaching experience. So now over to you, Dr. Prasad.
And over the last 15-20 years, we have seen him as an e-teacher. His presentations, his YouTube videos, they are very, very famous. His YouTube channel is very famous. Over to you, sir. Sir, you are self-muted. Oh.
Yeah, unmuted. Can you hear me now?
Yes, we can hear you, sir. Make it a slideshow, sir.
Yeah, okay. So can you see my screen, ma'am?
Yes, sir. We can see it.
Yeah. So good afternoon, everyone. So we'll be dealing with the SLOs for central nervous system. And there are 3 competencies with respect to CNS. And first competency is describe the etiology, types and pathogenesis, differentiating factors, and CSF findings in meningitis. Second one is classify and describe the etiology, genetics, pathogenesis, pathology, presentation, sequelae, and complications of CNS tumors. And third competency is they identify the etiology of meningitis based on given CSF parameters. So most of them probably require a lecture type or small group discussions. But the last competency, that is identification of meningitis by CSF parameters, probably we can conduct as DOAP or for skill assessment. Coming to the first one, they describe the etiology, type, and pathogenesis, differentiating factors, CSF findings in meningitis. First, I thought of SLO is the defined meningitis, even though it is not included in definition, I mean in the competency, but definition is a requisite, because most of these SLOs will go into questions. So you should have an SLO which is specified if you want to ask as a question format in assessment. So I included this defined meningitis and describe this can be a lecture, and all these SLOs just will be covered in 1 hour. So all these competencies can be covered in all these SLOs can be covered in 1 hour. Usually preferred thing is lecture, and assessment mode is written and viva. So describe the general morphological changes in brain in meningitis. So this also I included because they should understand the effects of meningitis, especially rise in intracranial tension, and that clinical assessment will help us if we deal with these general morphological changes in brain in the case of meningitis. And location of this acute exudate is also helpful in identifying the possible etiology for meningitis. So mainly it is in the form of lecture, or questions can be asked in viva. What are the gross morphological alterations that we may come across in bacterial meningitis or tuberculous meningitis of that sort, because these will have specific association or changes with respect to the brain proper. Okay. And third SLO is discuss the causative organism and route of entry of various CNS infections. And this is another SLO. This is again by means of lecture only. It can be combined with microbiology. So this is mainly microbiology feature, microbiology topic. Probably you can incorporate microbiologists to deal with this section of SLO. And describe CSF findings in bacterial meningitis, and all these things like lymphocytic viral meningitis, lymphocytic tuberculous meningitis. All these 3 can be covered mainly in the form of small group discussions. So this will give the student a grip to ask questions and clarify his doubts with the various parameters that are assessed in CSF in the case of meningitis. So this small group discussion will facilitate proper understanding of this subject, and assessment, of course, it can be written or skill-based assessment. And lastly, they discuss the differentiating features between viral, bacterial, and tuberculous meningitis, and mainly it is in the form of skill-based. And so a small group discussion will help us to clarify the doubts, and it can be written, or you can ask small, what do you call that, short answer type or short essays in assessment, or it can be a skill-based assessment, giving them the charts of different meningitis and asking them to interpret and the logical argument behind this interpretation. So with respect to competence, this competency 1, any discussion? Hello?
Yes.
Yeah, any discussion on this? Or shall we go
Anyone wants to ask something? Nobody's raising the hands. Okay.
Okay.
Yes, but as you said, this in the new curriculum, in microbiology, they have got CNS microbiology. I mean, the new curriculum, they have got distributed as CVS microbiology, lung microbiology, and CNS microbiology. And there, this topic is with a lot of emphasis.
So then we can have a shared session.
Yes.
Okay. So I will include this in the under shared session. Actually, I thought of doing it. I don't know what is the what is in microbiology with the CBME, but I had an idea that microbiology should go into clinicals, especially in the form of instead of talking or teaching them individual organisms, they should go into the system. Say, for example, UTI. The topic should be UTI, and the causative organisms that cause UTI should be discussed in group. And so is the pneumonias, and that will give hemolytic anemias. Probably organisms or parasites causing anemias can be a topic, and immunodeficiency associated infections. These are all specific entities. Probably that I'm happy to know that it has been included in CBME under microbiology. That's very good. And so this can go in for a shared session with the microbiology. Shall I go to second competency?
Sir.
The second competency is classify and describe etiology, genetics, pathogenesis, pathology, presentation, sequelae, and complications of CNS tumors. Actually, the CNS tumors as such, I don't think it is very important for the undergraduate, but there are some tumors like meningioma, medulloblastoma, astrocytoma, glioblastoma, which are important for a UG. But he should be in a position to identify the clinical manifestations of a CNS tumor, and this will help him to not to delay the case and give a proper referral. So first SLO is classify primary CNS tumor with the special reference to biological behavior, age, location in CNS. So this competency, SLO, I took from Dr. So I don't know, I have forgotten the name, I'm sorry. So this is competency with she gave a reference to the biological behavior, age, and location of the tumor. I think this is important to understand the different tumors occurring in different age groups, and also depending upon the location of the same tumor, the grade may also vary. So I think this should be there as a SLO. And describe etiopathogenesis and genetics of most relevant CNS tumors. I don't know, there is a lot of genetic genetics in CNS tumors. Recently, there is a lot of inputs, and it came into textbooks also. But I don't know how far it is relevant for understanding by an UG. But still, you can go for lecture in these two cases. And this genetics can be asked as a viva, asked in viva, to give extra marks to a good student, to differentiate good and mediocre students. And this other first SLO, that is classify, can be written on viva. And another thing what I would like to tell is usually the CNS has got no essay questions will come from CNS in pathology usually in our university, and most of them land in 5-marker or probably a very short answers. Okay. So probably the classify CNS tumors will never come as a question for a UG, but it can be discussed in, or it can be just included as a lecture. And I included 4 tumors like the meningioma, morphology of meningioma, so gross and histopathology, and morphology of medulloblastoma, astrocytoma, glioblastoma multiforme. So I thought these 4 tumors will be suffice to cover the entire spectrum of CNS tumors for an UG with the UG point of view. And describe the important clinical manifestations of CNS tumors, I told already. So this is very important in order to for a fresher to identify the CNS pathology and give proper referral. So this can be very effectively mediated by small group discussion rather than a lecture format. And these things can be asked as in viva. And describe the complications of CNS tumors. Of course, again, small group discussion and viva and MCQs we can set with this SLO. And describe the effects and origin of tumors that metastasize to brain. And this can be in the form of, again, small group discussion, or we must show a video demonstration as suggested by Dr. I forgot her name. I'm very, very sorry for this. Okay, so I took this SLO from her SLOs. Okay, so this can come in viva or MCQ for the assessment. Any discussion?
I think her name is Dr. Shagupta.
Shagupta.
Okay. Shagupta Barnek.
Okay, okay.
There are no raised hands, sir.
Okay, ma'am. Shall we go to next competency?
Yes, sir.
Yes, she's there. She's there. There's one raised hand.
Okay.
Hello,
Yes,
ma'am.
Yes, madam.
Good afternoon, ma'am. Can I?
Yes, please.
Can I
madam.
speak?
Yes, madam. Please speak.
Dr. Prasad, thank you very much for including our SLOs.
I'm sorry, ma'am. I have forgotten your name, but otherwise.
No,
Yes,
that's okay, sir. Just I have a comment because I was muted for the first competency. So there are around 7 SLOs that you have included. Just I was wondering that 7 SLOs means can we cover all of them in one lecture?
Yeah, one lecture is
and
enough.
Again, here we have 9 SLOs here. I mean, in 45 minutes. Basically, it is not even 1 hour. It is around 45 minutes. And in 45 minutes, you know, students have to punch. If we are thinking about post-COVID time, they need time for punching. So it actually leaves us with solid 40 minutes. So 9 SLOs in 40 minutes. Could we reduce them, sir?
Yes, sure. Sure, ma'am. So can we increase the timing or reduce the SLOs?
I think Prof. Bedi can, or Dr. Vinaya, they should be the ones to answer. If we can, I don't think that's the standard. The standard 45 minutes all over the country for any lecture. But
actually, madam, what you say is very true. 45 minutes only we can engage the attention of any students. Later on, the attention, downfall. Then we have to have some interactive session or something else. So I agree with you. At the most, we can go up to 50 minutes.
Maybe we can assign some of these as SDL or small group teaching and take them out of the lecture. So assign them separately, under lecture or as small group teaching or as SDL. Give it as an assignment. Some of them you can give it as an assignment to the students, and then give them an assignment during the session. So once you have given them assignment the day before, for example, to differentiate between different types of CSF findings in different types of meningitis. So you give them this assignment one day before they come to the to this session. They give them an exercise. They do the exercise, and you take the assignment. So you will have one more opportunity, not just to interact with them, but also to see how they are doing on their own in self-directed learning. And also you will have the third opportunity to give them some added grades if you later on decide to grade the assignment.
Yeah. Okay, ma'am.
Madam, very nice. Yes. Yeah.
Yeah, that is true. So thank you for that. Second competency, ma'am.
Yes, madam, anything on second? Okay.
Ma'am, same thing for the second. It's 9 SLOs. You see, and genetics and features. So if you are starting with the morphology, that is, as sir said, intracranial pressure and tension. So that itself will take at least 3 or 4 slides. Then let's just assume that each SLO will have 3 or 4 slides. If I just assign 3 slides minimum each SLO, so how many is it? Is 27 or 30 slides. So it is too much for a student to grasp in one session. So maybe some of this we can lump together or assign a separate teaching modality, not a lecture. Take them out and assign them something else. So then we are fine with the SLOs. We use different method in delivering it.
Yeah.
Now, what method will be preferable here? Because these are the tumors, madam, like meningioma, medulloblastoma, and astrocytoma.
Teaching, ma'am, small group teaching, because they need more close attention with the student. So small group teaching actually is very good for more complicated topics where you need to give more customized attention to students. So small group will be the ideal for all these dry topics.
Yes, madam. Very true. Okay, ma'am. Very well. Yeah. Yes, madam. Thank you, ma'am.
So we can incorporate all these things in during practical sessions, ma'am.
Okay. Yes. Yeah. Okay.
So
Dr. Lanjavar has written on the. Yes, Dr. Lanjavar. Yes. Sir, I unmuted you from your second link. He has written what about cryptococcal meningitis and cryptococcal and CNS toxoplasmosis.
Okay.
I mean, these are though not very common topics, but we sometimes mention them with AIDS.
Yeah,
yes,
So we'll be telling them. So should we teach them again in CNS and assess them in that?
Actually, when we are taking major CSF findings in bacterial meningitis comparison with tuberculous meningitis viral, there we can just touch upon and tell them about this
HIV meningitis.
Yes,
Right,
yes, ma'am. Yeah, and that picture, that chart can be made of a very characteristic India ink preparation slide, so that they become aware of it. Yeah. So,
Yes, we can make a passing mention of what comes in association with HIV meningitis.
Exactly. Yeah.
One of those.
Yeah.
Yes, ma'am. Right.
Shall we go to the third one, ma'am?
Yes, ma'am. Yes, sir.
The third one is identify the etiology of meningitis based on the given CSF parameters. It is actually a skill-based thing, and we suggested teaching learning method DOAP, and probably assessment also can be done during Viva in giving them cards for interpretation of that sort. So diagnose the type of meningitis based on CSF parameters provided. Usually we'll be giving them a chart for interpretation. So any comments?
Sir, this particular competency, we are going to go about it. So that means we have to give the students, this is going to be a practical session, and they have to do certain differentiating skills, right, between bacterial and viral meningitis. So that would include looking at the TLC and DLC, right, in addition to
Yes.
protein and glucose. So
Yes.
we have to plan a chart of what are the basic things that they are going to do in differentiating. So those will be the exercises, because this is a very difficult. I found this one as a very difficult, to be very honest.
Actually, you should ask them to do the test or what?
I mean, if it is skill assessment, DOAP, that is skills assessment, as I understand it, sir. So if it is a skills assessment, how we are going to assess the skill? That is the thing, by performing, right, sir?
Yeah. So,
Actually,
but
yes.
only allowing interpretation, is it okay?
Actually, traditionally, we have been allowing them to only interpret. We have prepared various charts regarding this, and we would take them during practical sessions. After demonstrating the brain specimens of pyogenic and tuberculous meningitis and meningioma specimen would be there, because this we get it from our autopsy. And after that, the charts are discussed actually. But DOP, like that is not the urine. Yes, we used to make them do as a practical, but not CSM. Because because sir, the volume which we get from the patients is also very
Yeah, I
little.
agree.
And,
Okay.
so charts will be fine. So that skill assessment could be like interpretation type, interpretative. It will go. Or
Yes, we can make it interpretative. I think that will solve our issue.
yes, madam.
And most of the colleges, they will have some material to demonstrate or illustrate the differences very easy. As you said, as you mentioned, the charts. So maybe other all institutions would have something like that already with them that they are working on. That will solve the problem. So we can make it interpretation. But they should be introduced to the techniques that are used for TLC and DLC and protein and glucose. They should know what tests are done to demonstrate these changes, these differences.
Okay.
Actually, madam, we do take that. We show them the needle, CSF needle, and the indications of doing the CSF analysis puncture. And then we also show gross may how you identify from subarachnoid hemorrhage to the traumatic tap. So that that too is done. Gross means like on the gross also cobweb formation in the lymphocytic thyroid or tuberculous, and so that is actually done. And then we go to chemistry, and then the slides, microscopy, and then gram staining.
That means, as you are saying, we can mention 3 subdivisions in this document. So one is the gross, or how you are saying the gross, and then we the types of chemistry that we are going to use in differentiating, and the procedure. So we can start with the procedure, then gross, and then chemistry. So we can give it 3 divisions, and so that will take care of unification, because every institution might be following a different thing. So if we mention it in the document, it will be a more streamlined approach to this particular competency.
So I will do that.
Yes, madam.
So that completes the CNS competencies. I will do the necessary alterations, and I will repost to the group, ma'am.
Sir, I will send you some pictures about some literature that teaching literature that I had actually worked on, and I had generated for this DOP session as a resource for the students. I will send that to you. You can include that, sir. That will be good for the students.
Sure, I will do that.
Thank you, madam.
I prepared some cases, charts, and MCQs. No, it is not complete. It is only just a few cases. So case 1, a 60-year-old male admitted with a history of fever, chronic cough, recently developed altered sensorium, headache, vomiting, and he had neck rigidity. Given below shows the base of the brain. What is the most probable etiology? So it is tuberculous meningitis because tuberculosis causes basal variety of meningitis. And second one, 60-year-old male treated successfully for tuberculous meningitis, recently developed vision disturbances and found to have oculomotor nerve palsy. And the image is given. What is the most probable mechanism? So here I would like to stress upon the fibrosis that occurs at the base of the brain, secondary to the exudative type that is seen in tuberculous meningitis. And this fibrosis causes the fibrous entrapment of cranial nerves. Probably effective treatment may be associated with the fibrosis and the cranial nerve palsies. So here fibrous entrapment in the cranial nerves is the pathology mechanism behind this cranial nerve palsies. And third one, a 7-year-old male child with acute suppurative meningitis developed petechiae and ecchymosis and shock. Autopsy specimen of the kidney with adrenals is given. So what is the most probable etiology? So adrenals show the hemorrhagic necrosis, and most probable agent that causes this type of adrenal necrosis or hemorrhagic necrosis is the Neisseria meningitidis. So what is the nature of this tumor? So the tumor is arising from the meninges, and it is compressing the underlying brain without infiltration, very well circumscribed margins. So it is meningioma. So case 5 is it primary or metastatic tumor? Just to tell that multiple tumors of different sizes usually indicative of metastasis rather than primary tumor. And these are some of the charts I prepared. 12-year-old child with fever and signs of meningeal irritation, and this is showing elevated pressure, opalescence, gross appearance, and reduced glucose. Protein is elevated, and a cell count of 6,000, and the type of cell is neutrophil, and this is acute pyogenic meningitis. Again, the same thing. It is the tuberculous type of meningitis because of lymphocytic infiltration, lymphocytes, and elevated count, and also high protein content with almost normal glucose levels and straw-colored fluid. And here you can add the cobweb also. And this other chart is the 35-year-old male with fever, vomiting, and signs of meningeal irritation. The pressure is elevated, and the appearance is water clear. The CSF is water clear. Glucose is almost normal. Protein is also normal. Cell count is elevated, and differential count showed lymphocytes as the predominant cell. So this is a case of acute viral meningitis. Some MCQs I prepared. This most common location of CNS tumor in children. They should know that it is infratentorial. So medulloblastoma exclusively occurs in the cerebellum. The bilateral acoustic neuromas are most commonly seen in. They are the markers of NF2. That's what I want to drive. And which one of the following tumor may show pneumoma bodies? Of course, here this is meningioma. And that's all. I have not completely prepared. I'm preparing some of the MCQs and cases and charts. When it is ready, I will post it to the group. So thank you.
Thank you, sir. Any feedback, Madam Shagufta, Madam?
No, ma'am, it's perfectly done presentation. No more comments. Just that there are some annotations on your screen. I think you did not switch off the annotations.
I don't know how to do it.
Yeah.
Okay.
He is deliberately using them as a special effect.
Thank you, sir. It was lucidly covering all the SLOs. Yeah, some more can be added, and Madam Shagufta, Madam is going to send you that so that you can incorporate and send as a full document to Dr. Sanjay Bedi.
Yeah.
Then we'll put it in the group, sir.
Yes.
Yeah. So I just wanted to say to all the participants, madam, now CNS is over. Yesterday, endocrine was over. Major topics in systemic pathology, like we have male genital, female genital, hepatobiliary system is also there, and then lymph node, and the whole hemat topics. Along with that, there are few miscellaneous topics like introduction to pathology, introduction to basic cytology section. In that, there is only one this, and ophthalmic only one competency. So all this is there. I'll send that list, which is the competencies which is not done, across to all of you all in the group just shortly. Today I will send. Then we have to decide about next Tuesday and Friday what topics to be taken. Actually, so how we can expedite was the look. And Dr. Hepatobiliary, Dr. Malini has done some SLOs. She was saying, she sent it across to me. I will, that hepatobiliary liver system, she was saying she has prepared some.
But ma'am, in the beginning itself, sir had assigned all of us two chapters. So you can go over that list and just generate.
Yeah, madam. Madam, actually, I went through all that. Yes, madam, I did go through all that. The dermatopathology was also there. So I went and spoke to them. What I realized, madam, is that everyone now has become busy with the COVID duties. Now, because majority of them, if they're working in the public hospitals, there are a lot of COVID centers are being set up. So they are assigned there and they have become busy. That's what. So when I spoke to them,
ma'am, you mean we are highly unemployed?
Madam?
You mean we
madam,
are highly unemployed? Ma'am, I mean, no,
madam, no, not at all. No. Actually, madam, even I do this after working hours at night time, madam. See, madam, this requires commitment and we are doing it. Of course, we are doing the daytime ka full work. I'm not saying that, but I did phone them personally, madam. Then they were saying they didn't look that interested. Then in that event, I phoned Dr. Malini. She said, I have hepatobiliary SLOs, because she was, I thought dermat ka few SLOs are there, few competencies. So we can just combine that dermat with a male genital and we'll speed up. So I did phone them. So this is what reaction I got. Then Dr. Malini said, yeah, though I've given dermatopath, mera hepatobiliary SLOs hai. So that will put it across. So that I think so fine tuning, if all the people join in and do it, it will get ready. I mean, I was just sharing my experience, madam.
You can post the remaining list in our general group. And
yes, madam,
wants to volunteer can come forward and finish it.
Yes, madam, I truly agree. For that reason, I was just putting it across today. Yes, madam. I'll put it that document today itself.
Okay, ma'am.
Sir, Dr. Sanjay,
ask on your behalf, sir. Dr. Lanjavar is asking, is there a competency of intracranial hemorrhage?
No, sir.
No, sir.
And degenerative diseases, it is not there.
Yes, sir. Maybe no, that has been included. That has been included in some other subject.
So it is only two, sir: meningitis and tumors.
But then
actually, madam, I think infection. Yeah.
And our student must know how to tackle that and actually diagnose that.
Yes, sir.
So maybe it is covered somewhere in the clinicals in medicine.
No, I don't think so. Hypertension maybe nahi ho raha covered.
Hypertensive hemorrhage and so on may be there.
No, it is not covered there. I don't.
No,
think
sir,
so.
madam, it is not covered there actually.
So whether it is covered
in forensic, that we have to see
I
whether
think we can add this and write to MCI to include it.
At least
Yeah.
send this information to
Can
MCI from our side.
I think
Yes, sir.
that can be, if we compile all the ones which are there, we can just write to them and
Yeah.
uh,
We'll do that.
basically we
Actually,
just have to write to Dr. Dubey and let's see what he, because he said it is a living document. You write to us and we will look into it. Changes are possible.
Sir, actually, if you may recall that in the beginning when we were presenting the SLOs, we did put some things as recommendations. So
Yes.
I don't remember if all of the people they did that, but in some of the ones that I presented, I did put a separate thing.
Look at
So
those
we can
recordings
include
and
it as
wherever it has been pointed out, then we can look at send it. We can compile it. Or we can send it to them one by one. This one is very important and we can send it right away.
Good.
Yes.
Yeah.
Thank you, Prasad, sir.
Voice has gone.
Thank you, ma'am.
Yeah. Yes, sir. That is why I have connected you to telephone. My you are speaking through my phone.
Okay. Thank you very much. It was a good presentation.
Thank you, sir.
Thank you, Prasad, sir, very much.
Thank you,
Very
ma'am.
beautiful. Thank you, Dr. Shagufta. Thank you, Lanjeva,
Thank
sir.
you, ma'am.
Thank you,
Thank you.
very, sir. Thank you.
And thank you, Dr. Vinaya, for taking such a this responsibility so emphatically that the whole thing is now moving smoothly. With 3 webinars in 1 week, we are now moving fast enough.
I hope so. Thank you, sir. Let's see. I will hope. Thank you, sir.
जरा कंप्यूटर पे लेक्चर चालू है.
Yes.
Okay, sir. Thank you. We can now close the webinar. Yeah.
Yes.